This session is really talking philosophically about the strengths and weaknesses, excuse me, but also the opportunities and challenges of using Medicare data, so that as you go through this process of designing your study, you're in a better position to see opportunities and to also understand where there are things that you might want to consider. And so that's really our point now, so that as you hear things going forward, you're going to be in a better position to ask insightful questions and put things into context. As before, there'll be time for questions at the end of the segment. If you have questions during this segment, please enter them into chat. Stephanie, Sammy, Abby, and a few others will be answering them, and they will interrupt if something is timely. Otherwise, we will have time for questions at the end. Just remember, and we've talked about this morning, that the claims data, the administrative data, are derived from the reimbursement or the payment of bills. So what that means is something that's really important that we don't always think about, which is the information needed to pay or needed to process the bill will always be of higher quality than other information. It means that we need to spend time learning and thinking about the payment process to understand, and that enrollment data that are the basis for determining whose bills are qualified to be paid. So as an example, and we will go through this tomorrow, in fact, we will say, well, this can't be missing, but it doesn't really matter what it says, or this is the basis of payment. And so understanding that will help you decide. And in some cases, what you will hear us say is, well, the basis of payment or the most important information depends on other things, which tells us up front that there might be inconsistent or uneven quality across different settings, which then means we get to have our fun, which is actually the thing I do really enjoy, which is to think about how we can determine whether or not we are making a mistake or introducing bias into our study. So as a reminder, Medicare data are administrative data. They're electronic in format, and they contain information about who is requesting payment, what is to be paid, and for whom are the services to be paid. So we've got numerators, denominators, and subjects. And they can be combined with information about the providers themselves, area characteristics, and other useful information. So when you put this whole thing together, you've got a tremendous resource and a tremendous ability to ask questions, to classify, to stratify, and to really understand and dig into the structure of healthcare and the outcomes of healthcare. So I'm going to start with just the sales pitch. Why use administrative data? First of all, they have strong clinical validity. They contain dates, which are always useful, admission and discharge dates, and that means we can put cause and effect, and we can sequence things. So the downside of studying prevalence, as you know, is all we know is at one point in time they were there, but we don't necessarily know how somebody got there. With dates, we can put something in and we can say, well, this happened, exposure happened before outcome, or the outcome was there, and then we had exposure, and then what happened afterwards. We have diagnoses. We know what was wrong, what somebody said was wrong with them. We have procedures, what was done. Was it an office visit? Was it a surgery? Was it physical therapy? Was it a prescription? We know what happened. And source of care, we also know where it happened. Was it in a doctor's office? Was it in a hospital? Did they bounce from hospital to hospital to hospital? Did they take an ambulance? How long was the ride? So we know all of this stuff, so we can start to tell a story about somebody. The demographic information, which is super important, is largely reliable and valid. And so first of all, age, date of birth, gender, race, place of residence, and date of death. And now this says not cause of death, but the reality is you can get cause of death if you can justify it, and we'll talk about that on Thursday, are all there and are all largely valid. In some cases, these are going to be tied to other things or relevant to enrollment. In other cases, they're not. But the other piece is we can link numerators and denominators together. So with some data sets, we know from one data source how many people were at risk, and we know from other data sources how many used, and we've got to make a decision. So as an example for that, state hospital discharge data tell us how many discharges they were, but they don't tell us how many people were at risk of being hospitalized. And we've got to just trust that the two belong together. And with Medicare data, we can actually put them together and calculate true rates. We have population coverage, and it's large. So for example, 98% of adults age 65 and older are enrolled in Medicare. That means about 54 million people are covered, which allows us to do tremendous subgroup analyses. If anything, our power problem was we have too much power, not that we don't have enough. As an example, I still remember the first time somebody proposed a study to study people, healthcare in people 90 and above, and I thought that was the most ridiculous thing in the world, because it seems like that should be a very small number of people, until we looked up, and I realized that it's millions of people that are eligible for that study. So things that any one institution could never do, with the Medicare program, we can. And in fact, over 99% of the deaths in the US for people age 65 and older are accounted for in the Medicare program. So what that means is even if people aren't enrolled at age 65, eventually, one way or another, just about everybody makes it in. But we have got to watch managed care enrollments. Now we've got this caveat, but we also have the encounter data, which we talked about. So right now we lose half the population due to managed care. We can say, well, can we live with only studying half of 54 million? Can we live with studying 26 million people? Or do we want to get the encounter data so that we can get everybody back? That becomes a decision we make, not because we lost half of 1,000 people, but because we might want to have different inference or ask a different question. These data are cost effective to use. And I think that's an important thing to understand. If you've ever done chart review studies, and nobody has to anymore, old style chart review studies were incredibly expensive and painful. But even now with studies where you have to get Epic access and try to get different EMRs or different systems to talk to each other, or figure out how you're going to read in the PDFs that are at the back, getting access across multiple providers, so getting from physicians and hospitals and other providers, such as home health agencies, is incredibly challenging, and it's expensive just in terms of time to get the permission. We also have to deal with challenges related to reporting format. Even with EMRs, there is no standard EMR format. And so it can be really expensive to get the data from primary sources. And in contrast, these are actually relatively inexpensive, and they're available quickly. So if you think about how long it takes to get something, where we've got maybe a year, a little bit more of a lag from the end of the calendar year to the files being available, it is hard to imagine that with all of the access and providers and alignments that we would be in a different position. So these are really useful because we can actually look at real-time questions. And in many cases, we need to do that. I think there's, especially with policy, especially with understanding emerging needs, there's not a lot of patience to wait 4 or 5 years to find out whether we should continue doing what we're doing. These data can be combined with data from external sources. And there's an asterisk, because one of the things you've got to remember, and you've got to spend some time doing, is to see whether you actually have the right information to do it. So for example, with the census or the area resource file, you can link it, but you may not be able to link it with the level of precision you want. Cancer registries such as the SEER Medicare data are linked and available directly. You don't need to do it. The VA has linked data, and so there's a VA Medicare linkage. And with Medicaid, because Medicaid is a state-federal partnership, it actually is pre-linked. You just have to request the data and explain what you need. CMS now, which is wonderful, has National Death Index data available that can be requested. It used to be that we had to go through the gymnastics of requesting it. Now we need permission. And part of that permission, just to sort of call it out, is to have a legitimate, specific scientific reason you need it. So you will not get the NDI, the National Death Index, linked because you're curious. But for some things you say, no, I really do need to know not just fact of death, like for censoring, but I actually need to know cause of death. You can do it, and you should be able to get it through, again, if you can make a scientific justification. There also are some surveys that are provided by CMS, such as the Medicare Current Beneficiaries Survey, the MCBS, and others that are provided through other linkages, such as the Health and Retirement Survey, and the assessment data that CMS provides, such as the minimum data set for nursing homes. So again, what's nice is that as rich as we may argue the claims data are, they can actually be added in with other sources to make them even more so. So then when we think about broad limitations of claims data, we've got to remember some things. And some of these are shared limitations from other things, and some of them are not. First of all, conditions must be diagnosed in a claim for services. So we've got conditions in the healthcare setting that are often underdiagnosed: hypertension, depression, diabetes, mild cognitive impairment, and they're often underdiagnosed clinically. And so one of the things we've got to realize is that if nobody says it in a chart, if it doesn't make it into a claim, then we're not going to find it. Now, there's two sides of this. One side is we won't find things since we don't know they're there. In some cases, it might be so common that we've got to ask ourselves, is this a sign about something else? And the example we usually use for that is hypertension. So hypertension, the prevalence of hypertension is probably in people 65 and older is well above 70%. And so some people have sort of suggested that an absence of a diagnosis of hypertension might actually might be a sign that somebody's just not getting regular health care. It's not that they don't have hypertension, that they might not, but we want to look at the context of, is this telling us something more than they're hypertension free? It's a record of care received, not care needed. So as an example, we don't know if about disease recurrence, but we do know whether they start getting new treatment or not. So for cancer, we can't see cancer recurrence, but we can see when they start getting more chemotherapy or different radiation therapy. The problem is that we can't always tell what that means. So we've got to watch. We know what we see, but we don't see what we don't see. And in some cases, somebody may get care they don't need and they miss care that they do. And we also have problems with denial. So again, the Medicare program, as I've said, is really quite generous, but there are services that are not covered. There are experimental services, there are preventive services that aren't included, and those won't always be submitted. And therefore, they won't always be there. So this is an issue that we'll talk about repeatedly, which is there are denied claims in the data. And the question is, what inference do we draw from them? If it's a non-covered service and it's denied, we can probably assume it actually happened. But if it's a non-covered service and it's not submitted, we don't know what conclusion to reach. So these are ones where we've got to recognize the nature of the billing, the insurance company, and what exactly we are seeing. We also have diagnosis codes, and sometimes diagnosis codes don't provide enough detail. So cancer diagnosis was ICD-9 until fall 2015 and moved to ICD-10. In ICD-9, it included diagnosis, but not stage or histology. In ICD-10, we definitely have that where you can see stage and histology, but you don't have to actually use it in order to be reimbursed for cancer care. And so we've got to ask if the code isn't being used, if it's breast cancer, NOS, not otherwise specified stage, not otherwise specified recurrence, what do we know? So we may know something, but we may not know enough detail to actually classify people into levels of severity. We also sometimes, and this is personally frustrating, is when you have a chronic disease And even though there may be codes that say worsening chronic disease, stable chronic disease, you don't necessarily know. So for heart failure, once somebody has heart failure, it can be really hard to assess, is this stable heart failure or is this progressing heart failure? And that would help us decide how to classify somebody and how to interpret cause and effect relationships between receipt of a treatment or not treatment and some outcome. And then finally, most diagnoses and many procedures have multiple indications. Nate, and this is his slide, says, consider antidepressants. There are many reasons that antidepressants are used in addition to depression. There are no diagnoses on the Part D event file. So we may know somebody received antidepressants or some other medication, but we don't know why. And so we have to make assumptions, and there certainly are algorithms trying to understand that, but it does mean we have to be very careful not to overreach or overinterpret. And then this is an ongoing issue, which is different care settings use different coding systems for procedures. So inpatient care, so hospital, anything, hospital, home health, well, home health isn't, hospital, nursing home, is used doing ICD-9 procedure codes, which are 4-digit, or ICD-10 procedure codes, which are 7-digit. But carrier and durable medical equipment is used CPT codes and HCPCS, which is the CPT codes are from the AMA. So they use different coding systems. Hospital outpatient care is CPT plus hospital billing center. So if we're trying to look at a service that could either be provided to a hospital inpatient or a hospital outpatient, we can't count on one coding system. So we have over the years done some gymnastics to figure this out, like finding the rendering physician and using their code or do other things, but do recognize that it can be difficult sometimes to make an apples to apples comparison of outcomes between, for example, inpatient and outpatient care, when not only are the care settings different, but in fact, the very way the procedures are coded is different. These are not insurmountable problems. It just means that we need to think about it and think creatively about determining what inference can we draw and how can we convince our readers and honestly sometimes ourselves that the crosswalk we have created is valid. And that's a lot of one of the things I said to one of my grad students the other day is, a lot of what we do as researchers we may say it's convincing our audience, but it's often convincing ourselves that we're doing it right. So do allow time for some of those questions and some of that process to happen. And then the other piece I want to remind you of is billing codes change over time. And we stop here because we've all done things where we've done very careful, in-depth looks to try to create our crosswalks. And then in spite of our very best efforts, sometimes the world changes and we're stuck without the answer we thought. So one of the things we have in CPT codes is there are these HCPCS, which are CMS codes. And codes that begin with G are CMS codes that are used for internal policy. We'll be talking about those tomorrow, I think. And as an example, CMS decided, because as a matter of policy, they wanted to understand use of preventive services. So they instructed people, in order to be reimbursed for screening services for prevention, they had to use the CMS codes, not the CPT codes. And so screening mammogram was coded as G0202, G0204, and G0206. And as you can see from this graph, we went along and it was being used, and it was being used steadily through December 2017, and then it just dropped off and we didn't see it again. So our challenge is, if we'd created a study that relied on the G codes, we would have been in a world of hurt starting January 2018, because something must have happened, right? Because the coding system, we don't believe that there were just no mammograms. But in fact, when we looked in 2018, CMS decided that they would use the CPT codes rather than the HCPCS, rather than the G code. So if you take that and you take the combination of the CPT code and the G code and you add them together, you get the gray line, which is steady all the way through the entire period. But the challenge is, in order to see this, you both have to be willing to look at patterns over time, even if you're not interested in time, and you have to be willing to ask yourself, what are all the legitimate ways the service can be coded, and be sure that you know them and look for them. So again, this is the challenge that I have, is that I'm not always interested in time trends, but I've learned over the years that I always need to look for them, because from time trends, I will see something that I am interested in, which is use of screening mammogram. I want to remind you all that there's some clinical information that's limited or lacking. Physiology, blood pressure, pulse, cardiac ejection fraction, we just don't get them. Test results are not included. PSA, so prostate cancer screening, we know if somebody had it, but we don't know what was found. Often, in fact, what we've learned is that the test will be coded with what they assume the outcome is, and that we can't, so it's almost like it's pre-coded and then the diagnosis goes away, because there is no diagnosis code for testing or rule out. So we know somebody had an angiography. We don't know what the result is unless, and there's been a debate. Some people have said, well, if you see a biopsy and you don't see anything else, assume the biopsy was negative. If you see a biopsy and then you see additional actions, then assume it was positive. But in fact, candidly, if we see a biopsy and then nothing else, all we know is they had a biopsy and then nothing else happened. And we don't know why. We don't know if it's that it wasn't needed, or if, as we said, that it was needed but not received. And if it's not received, we don't know why. We don't know if the patient or their family decided they didn't want it, or if it's never offered, or if there was a scheduling problem and they never got back in. We will see pathology. We will see that specimens were sent to the path lab, but we do not get path results. So that means in the case of cancer, we can't tell about things like margins, whether the surgical margins were clear or not. We can just see whether they got additional surgery. We cannot tell exact timing. So for example, hours from admission to event or timestamps. We cannot tell time of day for ER visits. So we don't know, we can't look to see whether ER processes are different for people admitted in the morning, on a weekday, or in the evening, or what time of day people tend to show up with certain things, because all we know is the date. And that means if we see somebody arriving in the ER on the 1st and something happened on the second also in the ER, we don't know if that was a lag of half an hour or 23 hours. So it's very important, if we have certain questions, that we are careful about whether these are the right data. I've had people who have come to me and say they want to know about use of TPA for for stroke. And it's like, we can't tell, or how long somebody is in the ER before they get transferred by ambulance to another hospital. We can't tell. We can tell if it was on the same calendar day or a different day, but we don't know how long it was. And then, so broadly, and this is also an issue with Medicaid, and it's also an issue with encounter data. Data are limited to covered benefits and for which claims are submitted. So prior to Part D, Medicare didn't have a pharmacy benefit, so we couldn't study outpatient medication. We didn't know. We didn't know if somebody got tamoxifen or aromatase inhibitors or nothing. We just knew that if they got medication, we couldn't see it. With Part D, there are formularies, so we don't know if they didn't receive something because it wasn't on the formulary, or if it was on the formulary and they just didn't receive it. But also, if a claim isn't submitted, we don't see it. An example that I've used for years is my grandmother lived in a small town in central Minnesota, and I was talking to my mother quite a few years ago, and she was telling me that she took grandma up to get her flu shot, and that when they got there, they realized she'd forgotten her Medicare card, and they didn't want to drive all the way back to the house to get the card and then all the way back into town. So I said, so what did you do? And she said, oh, it turned out it was $10, so I just paid for it. And the answer was, well, that makes total sense for an individual, but I'm thinking to myself, I'm glad she got her flu shot. She was in her 90s at the time. but I realized I would code her if I was using Medicare data and she were one of the people, I would code her as having not received a flu shot. So then we can say, well, what would the bias be? Well, in this case, the bias would be that we might underestimate the value of flu shots because some number of people will be false negatives. We're going to code them as not having received a shot. And in fact, what they did is they went through some clinic and the price was so low, they never billed it. There are services that are not covered. There are coverage decisions that are changed. There are coverage decisions where certain procedures have other limitations. I encourage you, if you're looking at something that is a new procedure, something new, to make friends to go explore the coverage database. This is a fascinating database, and it will tell you and look things up if it's covered, how it's covered, how long it's been covered, and whether there are any conditions or other information that you need to meet. As an example, with the coverage database, in order to get covered for bariatric surgery, you have to have a diagnosis of morbid obesity. Coverage database would tell you that. So if you're doing a study of the outcome of bariatric surgery, this might help you better classify or create a comparison population. Just remember Part B, services for managed care enrollees. This needs to be updated, but until 2015, we didn't know what was going on for managed care. We don't know what medications people who don't have Part D coverage get because they're not contained in the file. So do think carefully about who you're including and who you're excluding in your population. So as we've said, my general broad rule is if it impacts payment, the quality will be better than if it doesn't. And the corollaries are different types of care may be subject to different rules. And please don't forget that there will be measurement error. And so do stop and think about what are the ways that we can minimize it, that we can look for face validity, that we can do our little logic checks or big logic checks, since we spend a lot of time doing that. In general, the elements CMS provides are going to be consistent. Our record layouts, which you can see on ResDAC's website, will provide information about assumptions, data combinations. And so please keep them handy, know where they are, make sure you have them available, because there will be times when you're going to think something works a certain way, and you're going to want to look it up to say, why isn't this pattern what I would expect? And often what we find is that it's because we made assumptions based on a variable name that in fact may not mean what we think it means. I also want to point out, and we'll talk about this again on Thursday afternoon, the structure of the Medicare program. The structure of the Medicare data is complex and it's different and it's challenging. So just to help you understand, each person has one enrollment record per year. Everybody has a variable number of hospitalization records per year. Each person has a variable number of home health agencies, skilled nursing facility, hospice, and outpatient carrier records per year. Each of these records is divided up into multiple files that can have multiple and variable number of segments. And as we said earlier today, an event, a healthcare experience may have records across multiple files. So the data management challenges of this are incredibly complex and different from a lot of other data. So we spend a lot of time working on how do we roll it up? I noticed in the chat earlier, there were questions about deduplicating. And the answer I would say is they're not frank duplicates where it's the same record twice. It is where the same experience, the same thing we want to count shows up multiple places, and we have to decide, is it one event or is it more than one event, one thing worth counting? So when you want to use the data, just really stop and think. One of the things that I see a lot, and it's not new, is that people rush. They're impatient. The process takes time. And it's like, we just want to just give me the data. I'll figure it out later. And we hear that all the time. But there really are 3 steps that you have to do when requesting data from CMS. And having rushed through this, I will say, I encourage you to take the time to do it. So first of all, really stop and think, who do you want to study? This isn't always as straightforward as it sounds. And in some cases, given the study size, you'll get pushback. So we say, I want to study people with hypertension. And CMS will come back and say, so you want 22 million people. Can't you narrow it down? Can you deal with the sample? Do you really just want hypertension or do you want something else? The next question you want to figure out is, well, what is it you're trying to measure? What is your outcome that you're trying to find? We want to make sure that you design a study that will let you find your outcome that you need, but we also want to make sure that your outcome is findable. So by stopping and doing that before you get the data, it can save you an awful lot of time. And in some cases, it may help prevent mistakes. And I certainly have my share of war stories where I rushed through these and then had to figure out how I was going to get out of a jam that I created for myself. And then the other thing is, think about what are the key adjusting variables, the things that you really need to know about. So as an example, I want to look at screening for lung cancer. Well, one of the big adjusting variables, the big risk factors, is smoking. And although there are codes for smoking, they are very rarely used other than for people who want to justify lung cancer screening. So my question where we get stuck is, well, can I actually identify the factor that's going to help me link and control my inference? Can I find smoking? Can I find obesity? But also, can I find age? Can I find where somebody lives? And make sure that you can find what you need, that you're looking in the right place, and do that before you start asking for data. It's a whole lot easier. So come up with a clear definition of your target population. An important rule, and this may sound super obvious, but you'd be surprised, is everybody in your denominator must be eligible to have events. And that may sound simple, but I am shocked at the number of times people will do something like they will forget to restrict for a study of female breast cancer. We'll forget to get rid of the men. So think about those things. Or you want incident heart disease. Well, that means you want to get rid of the people who have heart disease at baseline. There are questions where you can walk yourself into sort of a circle. And this is one that's my personal favorite because it's one that caught me and took me, and it's always one we have to stop and think about. I want continuously enrolled. But if I say I want people continuously enrolled for 5 years and I don't say anything else, the way it often gets programmed is we'll take people on January 1st, 2020, let's say, and it will keep everybody who is still in Medicare on December 31st, 2023. Well, what does that mean? It means I haven't allowed any new people into my study, so my study is aging. But I'm also requiring everybody to be there, which means I have actually restricted and removed people who died. And if you're even more restrictive, you might remove people who move in and out of the area. So a very simple thing of I just want a continuously enrolled population is not as simple as it seems. And you're going to want to make sure you ask for that and think about it, because either at CCW, which is who distributes the data, or even with your programmer or analyst, they will do their best to implement the study as you have described it, but that may not be actually the study that you want to do. So these are places where the inference and the stopping and thinking about what is it I'm saying and what are the impacts of those things is absolutely essential. So when you think about the population to be studied, the question is often we cannot use diagnosis or procedure. And as I've said, rarely is there a single diagnosis, and often multiple diagnoses will apply. And clinically, unless it's required, we'll get this NOS, or not otherwise specified code. So yes, the codes can let us specify stage or grade for a cancer or level of heart failure, but we have to decide what happens if someone just has heart failure. Do we keep them? Do we get rid of them? How do we use the codes and use their imperfection, knowing, as we said, that these are used to justify billing and we need to be strategic about what it is we include. We can also think about demographics. Is there a particular age or gender that we want, or a race, area of the country? Do we want to restrict it to a specific coverage group, Part A, Part B, Part D, managed care, et cetera? And do we want to limit it to people in a specific program? Elderly, disabled, end-stage renal disease, ALS. How do we want to do this? We need to think about the outcomes of interest: receipt of diagnosis, duration of care, time till event. How long did somebody have? How long were they there? Mortality, again, we can use date of death is easier than cause of death. There's healthcare use, and there are algorithms that you can use to identify avoidable stays, ambulatory care sensitive conditions, certain types of procedures, transfers, money spent, total reimbursement, co-payments, deductibles, and so on. So there's a lot of outcomes we can use. If anything, the outcomes are the easy thing. The question is, what are the control variables we need in order to be able to make those decisions and reach conclusions that we think are helpful? Time trends, and I said this earlier, and I'm going to repeat myself about 14 times. Even if you don't care about time trends, if you are looking at data over time, you need to look for them. Major payment policy changes. One I'll give you because it's easy is DRGs began in 1983. The data don't go far, but if you think about that was a policy that changed overnight. We also gave you other examples. Medicare managed care has changed. The rules about who is eligible, what type of plans, and with those changes come other changes. So if you remember again, when we looked at that curve that showed managed care enrollment, you remember it was steep and then flat and then less steep. Those are all policy changes that impact what I see, even if I say, well, I'm not interested in policy. There are changes in the granularity and the details of the availability of the data, race. There's the RTI race. There's the mechanism of injury codes, and so on. So data change, the change from ICD-9 to ICD-10 is, again, a massive change. So if you're looking for something and something else is changing, it makes it hard. An example of this, and again, we said earlier that CMS doesn't make changes thinking about science. There was a major change in the way home health is paid. The change was implemented in January 2020. So right when this change was implemented of how home health is paid, we went on a COVID shutdown. So how do we figure out, or can we figure out, or do we just have to give it up as unknowable, what the impact of that payment change was? Right? So, I mean, those are the things that happen where, and at the same time, we could say, well, we could ask either question. How did home health get affected by the change where COVID is the problem? But we also can't ask, how is home health used during COVID when we've got this confounding of a major payment shift that would happen just in our pre-period that we would normally use to get a trend? So those are the things. So even if you want a trend, and even if you don't want a trend, take time to look and to make sure you know what's going on. There are changes in codes, there are changes in policy, and they can be quite frustrating. We talked about adjusting variable. Do confirm that your important covariates can be found in the data and in the files and in the years requested. Just because something looks like it should be there doesn't mean it actually is. My usual mantra is sample wide and analyze narrow. So what I mean by that is, when you're making your request, make sure you're comprehensive and thorough, but reasonable. So CMS policy through HIPAA, there's a minimum data necessary. So there will always be this need to balance what is possible and what you need. But if you're too narrow in what you ask for, you're not going to be able to figure out if you're missing something, and you might be stuck. But nothing is gained by having a whole lot of records that are poorly defined. So it's a dance. It's like a lot of other stuff with this, where you need to be able to balance the size, wanting more records, and wanting a cohort that is pretty coherent and has got things that are similar to each other. So that is our dance. Those are the strengths and weaknesses, and honestly, where some of the opportunities are.